Okay, so guys, good evening, and I welcome you all to this, the masterclass of pharmacotherapeutics. And as there are two sections, there are two episodes. One is today on NAFLD, non-alcoholic fatty liver disease, and one is on Monday, right, on myocardial infarction that I'm going to take. So, because we were starting, sharing this class today only, it was quite late, but I wanted all of you to join here, and I appreciate that many of you have joined, and here also in the registered also. So one thing I want to share, guys. Okay, one thing I want to share that this class is certified class. Okay, whoever is attending both the episodes today and Monday will get the certificate, and this is a paid class. Okay, this is a paid class. Today we kept it free for everyone. Today we kept it free for everyone, the first class. So everyone who is joining here, if they are interested to get the certificate and to complete the master class to get the certificate and want to complete both the classes, you can register to our pay, because we have already launched it a few days back, but we couldn't share before. So I thought to keep it free of cost, first class for you, on NAFLD. And then if you want to complete the entire master class with MI also on Monday, you can just pay 19 rupees and register for it for certificate. Okay. So that's all from my side. We'll be sharing the link at the end of this class. At the end of this class, we'll be sharing the link for registration. If you are interested, you can register. Okay. And my pharmacotherapy people who have joined our pharmacotherapy module 1 course, it is free for them. Okay, it is free for them. You don't have to pay anything, guys. Remember, the people who have joined pharmacotherapy module 1, it is free for them. You don't have to pay. And if you are paying, you will be paying at your own risk. I'm not going to return that money. Okay, so don't pay. I'm warning you, the people from my pharmacotherapy module 1, you don't have to pay for this masterclass. Both the classes are under your pharmacotherapy module 1, so you don't have to pay. This is for the new people who wants to just join the masterclass. They can join the masterclass by paying 99 rupees if they want the certificate of this. Okay, otherwise they can just enjoy the NAFLD. They can enjoy the class. This class is going to be very fantastic, because this is the specialization of Dr. Siddheesh Rajpurohit, who is going to take this class. And you must have attended the the multiple classes from him in CCBGH. He has completed his CCBGH master's course with us. So I think that's all, guys. You will be getting the link at the end for the feedback and for the registration also. If you are interested, you can register for the master class. Only the pharmacotherapy module 1 people don't have to join for it. Okay, guys. So over to you, Dr. Siddhesh. Go ahead, and thank you very much.
Thank you so much, sir. So as I got to know that people are here from B Farm first and second year, so we will try to cover the basics first.
Your voice
So,
is a little low, Siddhesh.
is it fine now?
Speak.
Hello, is it fine now?
Yeah, okay, manageable. We'll go ahead.
Manageable? Okay, I have one more.
I think you're a little away from the iPad.
Is it fine now?
Same thing.
Same thing.
Yes.
Give me just 30 seconds. So, is it fine now?
Yeah, okay. Go ahead.
Okay, manageable, right? Audible. Okay,
Yeah,
fine.
yeah, yeah, go ahead.
So, yes. So let's start with the NAFLD class. So as we are having many young individuals, budding B-Farm, PharmD people here, so let me clear some basic terms that is going to revolve in the entire class. So the first thing what we are having is the NAFLD, and along with the same part, we are going to learn about the NASH also. It is nothing but NASH. So two things in this class we are learning. First is NASH and the NAFLD. So NAFLD is very common. That is non-alcoholic fatty liver disease that might be we all are having. And NASH is what? Non-alcoholic steatohepatitis. So what is steato? That is fat. What about hepatitis? Liver inflammation. Itis, that means inflammation. Hepatitis, that means liver inflammation. Liver inflammation. Now in the coming class, I'm going to show you multiple features of both the categories NASH and NAFLD and how to categorize these two parts by using the pathological image. Remember, ultrasound cannot distinguish between NASH and NAFLD. Now, few things that you should all remember, I might going to ask you in the end. So in the NAFLD part, remember, we are having hepatic steatosis. That means fat accumulation. What about NASH? In NASH, two things will going to happen. There will be a presence of lobular degeneration, lobular degeneration, and also we are going to have the presence of ballooning of hepatocytes. So what is ballooning of hepatocytes? It is nothing. If you are having the hepatocytes, hepatocyte size might increase to 2 to 3 times of its normal. So basically, this is the dead cell. This is what a dead cell of the liver. So this is what we differentiate between NAFLD and NASH. NAFLD we all might be having, but not NASH. NAFLD will progress to NASH, but not reversible. So in our liver, we have two lobes. It's a very simple we are discussing till now. So in our liver, we are having two lobes, correct? We have right lobe and we have left lobe. Now these lobes are made up of thousands of hexagonal structures. Remember your chemistry classes, we used to draw a lot of benzene structures, right? Like this. So this is how it appears, hexagonal lobules. And if I zoom in with the help of microscope, I am able to see the hepatocytes and the sinusoids. So it appears like this, and we are having multiple hepatocytes and the sinusoids cavity. Now, this black dots, what I am drawing is the hepatocytes, a basic unit of liver. So what is the basic unit of kidney? Anyone? What is the basic unit of kidney? Nephron. Nephron, perfect. Perfectly fine. What about brain? What about brains now? Yes, neurons. The same way we are having for the liver, that is hepatocytes. So I hope this part is clear till now. The NASH and NAFLD thing. So do we have any doubts now with respect to NAFLD or NASH? Clear? Others? No doubts? Okay. So let me zoom in again to our hexagonal structure that is known as lobule. This is what your lobule in which we are having this black dots. These black dots are known as what? A hepatocytes. Known as what? A hepatocytes. This space is known as what? A sinusoid. Sinusoid. Clear? Simple structure. So this is the simple anatomy of liver along with the basic clear definition between NASH and NAFLD. Now, coming to the main introduction part about the NAFLD. So this is what? So global obesity. Let me change my pen color. So global obesity epidemic has dramatically increased the prevalence of NAFLD and made it the leading cause of chronic liver disease. So what is chronic liver disease now? Liver cirrhosis. NASH will change to liver cirrhosis. Then it will change to hepatic cellular carcinoma or liver cancer. This is all a CLD part. Now, NAFLD is considered the hepatic manifestation of the metabolic syndrome and shares a strong association with type 2 diabetic mellitus. Why diabetic mellitus? Anyone? Anyone? Why diabetic mellitus? Anyone? PharmD senior people? 6th year, 5th year? Any guesses? Produce insulin. It's not that part. It is because of the insulin sensitivity. It is because of the insulin sensitivity. Correct? Now, Ludwig and its colleague coined the term NASH in 1980. So how come they find about the NASH term? So what they have done, they have got multiple patients in their clinic. They have found that these patients are having what? A hepatomegaly. So what is hepatomegaly? Enlargement of the liver. So they were suspecting some alcoholic abuse. So what they have done, they have performed the liver biopsy and they found a entire feature suggestive of alcoholic hepatitis. Alcoholic hepatitis. Now, the turning point was all the patients were non-alcoholic. All the patients were what? non-alcoholic. So something was there among the non-alcoholic patient that resembles with the alcoholic hepatitis. That's why we have a term that is known as NASH, non-alcoholic steatohepatitis. This is how NASH came up. Clear? Any doubts? Anyone? Do we have any doubts now? Simple thing we are dealing with. Suhana, which part? Repeat which part, Suhana? NASH part. Okay. So what happens in 1980? Ludwig and his team got multiple patients with the liver inflammation or liver enlargement. In medical term, this is known as what? Hepatomegaly. So what they have done to diagnose the condition, they have performed the liver biopsy, and on the biopsy, on the pathological imaging, they have found the features suggestive of what? Alcoholic hepatitis. But the best part was all the patients were non-alcoholic. All the patients were what? Non-alcoholic. So that's what came up with the NASH. So NASH is what? Non-alcoholic steatohepatitis. Remember what is steato? A fat. What about hepatitis? Liver inflammation. Correct? Simple thing. Doubt clear? Suhana? Others? Yes, perfect. Now we have one thing that is two-hit hypothesis. Now I will make it very simple for you all. So remember my two simple things. Now, one thing, our first hit. Remember this term, two-hit hypothesis, but this is what, let me make it very simple for you all. Now, first step is what? Fat accumulation. First step is what? Fat accumulation. Second step is what? Oxidative stress. Oxidative stress. Fine. Now, what is happening in the first part? You are eating a too much of food, junk food, cold drinks, or sugary foods. So what is going to happen? This will go and store in your liver from the intestine part. Correct? This is what a starting of your NAFLD. This is known as what? A fat accumulation in the liver. If question comes, which type of fat? Then answer is very simple, triglycerides. Answer is very simple, triglycerides. Now, at certain point of time, liver can store the fat and can be used in the terms of starvation or fasting mode. What happen if we are giving daily basis of lot of fat to our liver? It is going to accumulate in the liver. That is what? A fat accumulation. Second part is what? Oxidative stress. Now liver is fed up of your fat. So what is going to happen? Liver is going to stress. So once liver is getting into the stress part, it will cause more amount of inflammation. So once you are getting the inflammation, this will result in what? Steatohepatitis. So the first part is what? A classic NAFLD. Second part is what? Steatohepatitis. Fat plus inflammation. Correct? And patients with the steatohepatitis are more prone to change to CLD rather than patients are having only NAFLD part. Fine. Now, the next thing what we are having is the epidemiology part. Uh, Pushpendra. Okay, Pushpendra. So what you people can do is like, if you want, you can take the screenshot and Pushpendra try to focus on what I am trying to write in the screen. You can take a screenshot, Pushpendra, for the meantime. But just try to focus on what I am going to teach you while writing. Fine. The next thing what we are having is the epidemiology part. This is all numerical part, all simple things. Now, the rise of NAFLD has paralleled with the rising rate of obesity. That means obesity is proportional to the NAFLD occurrence or the prevalence. In 2016, 39% of adults in the USA qualified as overweight and another 13 were obese. These figures are triple the rate of obesity described in 1975. Too much obese people we are getting nowadays. Because the majority of patients with NAFLD are asymptomatic, the prevalence of NAFLD in USA and globally is not completely defined. Even suppose in this class we are having around 180 individuals. So if I'm putting my ultrasound probe on your liver, so out of 180, 179 might be having grade 1 fatty liver. It is very obvious thing. Most relevant studies have reported NAFLD to be more common in men than women. Can someone answer me why men than more than women? Anyone? Pushpendra? Najia? Anyone? Why men are developing more NAFLD than women? Smoking, not that much related. Enzyme metabolism, not that much. Alcohol, of course. Alcohol intake, yes. Yes, perfect. More alcohol consumption. Yes, lifestyle modification. Biological composition, no. Alcohol, smoking, perfect. All are going perfectly fine. So, a simple answer is what? Alcohol consumption. Simple answer is what? Alcohol consumption is more in men compared to women. Okay. Now, NAFLD and NASH are is associated with the diabetic mellitus with 60 to 76% prevalence rate for NAFLD and 22% prevalence for NASH. Perfectly fine. So if you are diagnosed with NAFLD, you have to control your NAFLD progression. Otherwise, it will change to grade 2, grade 3 and NASH. But this disease is common in non-alcoholic patient. No, sir. Ramya, this is what we are dealing, non-alcoholic fatty liver disease. So here we are dealing with patients who are non-alcoholic only. So patients who are drinking alcohol will not be taken up as the NAFLD diagnosis. How alcohol? Alcohol, because this is the major thing. See, you have to learn the differentiation between significant and non-significant alcohol intake as well. If you are drinking daily one beer, it will not going to cause any problem. This is not the significant drinking. This I'm going to show you also what is significant. Okay, let's discuss this now only. Now, as per the test books, significant alcohol intake is not what we are doing on daily basis. Correct? Now, this is what a 14 gram of alcohol if you are taking. Now, suppose in this class we have some people who love beer a lot. Okay. In this class, we are having some individuals who love beer. Okay. So remember this part. Okay. First of all, male and female that we all should know. So as per the standard drink, which contain what 14 grams of alcohol, how much man can take? Equal to more than 4 standard drinks per day. If any man is taking 4 or more than 4 standard drinks per day, or any female is taking more than 3 or equal to 3 standard drinks per day, which contain how much? 14 grams of alcohol per drink, right? This is going to cause a liver injury or liver problem. Now, suppose in this class, people are drinking some beer. So beer, how much we can drink? So it is like 350 ml. 350 ml of beer contains 14 gram of alcohol. So if you are drinking 4 bottles per day, you are prone to develop some liver disease. What about people who love wine, who want to show red wine, all those things? So wine around 148 to 150 ml contain around 14 gram of alcohol. This is what known as significant alcohol intake. Number third, people who love hard drinks, whiskey, vodka, rum, and all those things, which contain 14 gram of alcohol, around 30 ml of drink. So if you are drinking 4 shots, suppose you are taking 30 ml 4 times, you are taking 14 grams. So if you are taking 4 glasses every day for more than 4 days, then you are prone to develop what? A NAFLD, and after more liver disease. This is what I'm telling Mohammed Noor. Like, we are not dealing with the non-significant, we are dealing with the significant. So, alcohol intake, high sugar intake, fast food, your diet, lifestyle, all are the factors linked with the development of NAFLD. Vrinda, see, if you are crossing your standard drug limit, alcohol limit, you are going to cause damage to your liver. You might develop little bit inflammation by next day. It is not like you are drinking today 12, 30 ml shots and then you're nothing you are drinking in that part. So here we are dealing with the non-significant alcohol intake, not the permanent more alcohol intake. So if you are getting confused for such part, remember we are dealing with the non-significant alcohol intake, not the main alcohol intake. Both, Malika Arjun, both high sugar intake, alcohol, your lifestyle, your more sugar thing, your cold drinks, your fast food and everything, all will going to increase your NAFLD part. Am I audible to everyone? Pushpendra, like others, am I audible? Yes. So I hope that part is clear now, that men and women part. Clear? Yes or no? Okay, so do we have any doubts now? Any doubts with respect to that alcohol part? No, perfectly fine. Okay. Now, the major parts, lifestyle modifications, increased consumption of high fructose corn syrup, sugar containing sodas, coupled with sedentary lifestyle, lazy people, has been associated with a higher rates of NAFLD, specifically NASH afterwards. So go and have one ultrasound, then do your LFT. If it is showing NAFLD symptoms, then stop drinking sugar foods, stop eating sugar fruits, stop eating junk foods, do some daily exercise. Pushpendra, we can discuss all these things afterwards. It's not the significant what we are discussing. Does not matter who is coming, who is not coming. I believe you people should be focusing on the class as such of now. Okay. The major thing now is the definition and the association with NAFLD. So how to tell whether my patient is having NAFLD or not? So macrovascular fat accumulation in more than 5% of the hepatocytes is defining as the feature for NAFLD. Perfect. If someone asks how much fat, 5% or more than 5% in the hepatocytes. Now, IFL compromises. What is IFL? Isolated fatty liver. It comprises the majority of the patients with NAFLD. So in this class, if I'm having around 190 individual, 188 might be having what grade 1 fatty liver. So you all are what isolated fatty liver patients, not the NASH or the advanced NAFLD patients. Now, hepatocytes ballooning, degeneration, and lobular inflammations is the clinical feature or the pathological feature for NASH. Now, to reach the pathological classification of NASH, Pathological Committee of the National Institute of Health, NASH Clinical and Research Network proposed a scoring system incorporating of the 14 features in the 2005. Now, this is the scale that will be used by the pathologist during the screening of your liver biopsy. Now they will going to count your steatosis, that means your fat percentage, whether this is more than 5, less than 5. Remember, the cutoff is what? 5%. That's why we are starting with 5. Correct? What about the ballooning part? None, few, many. I'm going to show you how this things appear under the microscope as well. What about the lobular inflammation? Mild, moderate, severe. Now, pathologists, by looking by use of some AI system, they're going to mark your biopsy. In the end, they will get the total score. So 0 to 2, nothing, no need to worry. About 3 to 4, intermediate NASH. 5 to 8 is what? Likely NASH. Perfect. So if you want, you can ignore this table as such of now. This is only for the people who are in the starting 1 to 3rd year. Others, remember this part, what we are using for marking for NASH part. So do we have any doubt with respect to this part? Anyone? Anyone? No? Others? Alisha, Akshaya, Angel, Angelina, Anirudh? PK Malani, the thing is, we cannot differentiate NASH and NAFLD in ultrasound. So to identify whether my patient is having NASH or NAFLD, we can go with the NASH, we can go with the liver biopsy. Liver biopsy we are performing only to confirm whether my patient is having NASH or what grading he is having for the NASH part. NAFLD, we can easily diagnose it by using ultrasound. No need to worry, in the coming class, we are having some ultrasound images also. So that part will be making more clear to you. Okay, so do we have any doubts now? No doubts? Perfectly fine. The next thing what we are having is the pathophysiology, that the pathogenesis. Just try to listen to me. I will try to make it very easy for you. Now, hepatic steatosis, that means fat in the liver cells, is the hallmark of NAFLD. And excess accumulation of free fatty acid is the clinical feature, more than 5%. Clear? Normally, free fatty acid is supplied to the liver by the intestine. So if you are eating lot of junk food, lot of fatty food, those triglycerides, those fatty acids will going to travel to your liver. And where this fatty acids will be stored in the form of triglycerides. Now, suppose if any patient is there who is doing a lot of fasting or starvation, so our adipose tissue going to release more amount of triglycerides in the blood, and it will go and store in the liver as well. So starvation, long-term fasting is also responsible for the development of NAFLD. Remember this part. So losing only weight will not able to solve your NAFLD condition. So if you are doing starvation or fasting, you are causing more liver injury. Perfect. Now, in your liver, this free fatty acids will be converted to the triglycerides, will be converted to the triglycerides with the help of what? Mitochondria. With the help of what? Mitochondria. Simple. This might be in your MCQs in the upcoming exams. So remember this part. In your liver, free fatty acids will be changing to triglycerides with the help of what? A mitochondria, right? Along with the triglycerides, it is going to form what? Some amount of phospholipids as well. Phospholipids. Now, hepatic triglycerides accumulation occur when free fatty acid metabolism shift to favor lipogenesis than lipolysis. So what is happening among patients with NAFLD? They are having more lipid formation rather than lipid breakdown. So if your liver is promoting lipid formation, then you are more prone to develop what? A NAFLD. Your liver should be promoting lipolysis. That means breakdown of liver fat. It will going to prevent what? Your NAFLD. You might have seen many patients are eating lot of junk food, but their liver is completely fine on the ultrasound. Why? Because their liver is promoting what? Lipolysis, not lipogenesis. Uh, Ramya, sir, once again from phospholipid. Okay, so remember this part, a simple thing. So if you are eating a lot of junk food, lot of sugary food, what is going to happen? Your intestine will absorb lot of free fatty acids, and then this will be transported to your liver. In your liver, this free fatty acids will be changed to triglycerides and phospholipids by the use of what? Mitochondria. Simple thing. So once you are having a lot of triglycerides, so what is going to happen? Your liver will promote lipogenesis rather than lipolysis. Some people eat a very less food, but they are gaining a lot of fat. Why? They have high amount of lipogenesis. Some people eat lot of food, but they are very thin. Their liver is completely fine. LFT is fine. Ultrasound is fine. Why? Because their liver is promoting lipolysis. That means breakdown of fat. Correct? I hope this part is clear now, Ramya. Any doubts? Yes. Okay. Now, let me give you one more advanced touch of NAFLD. So, there is one sugar known as fructose. There is one sugar known as fructose. Apart from fructose, Swati, we will cover the same part in the coming class. No need to worry. So, in the entire carbohydrate class, we have sucrose, we have glucose, fructose, galactose, and all part. So among all the carbohydrate, fructose is the only sugar that can directly imported, that can directly come into your portal circulation. And where we have our portal circulation? In our liver. Perfectly fine. Now, this is only for the people who are in the higher classes, not for the B Farm first, second, or B Farm D first, second. Okay. Now, once fructose is coming to the portal circulation, two things going to happen. That two things are what? This can be in your exams as well if you are planning for uh, pharmacy licensing exam for other countries as well. So this fructose can activate two different pathway in the liver. That is what? One is what? Carbohydrate. One is what? Carbohydrate response element binding protein. Binding protein. Other thing we have what? Sterol regulatory element binding protein. Binding protein. Once these two pathways are activated by fructose, this will automatically going to promote what? Lipogenesis. So more lipogenesis, more fat accumulation, more NAFLD progression to NASH and chronic liver disease. Perfect. Malika Arjun, yes, no, not bilirubin. It is going to increase the ALT and AST. Just give me a few minutes. We are coming to the diagnostic part as well. Nausea, people need to be very active. If you are lazy, your liver will not work that much. That's why after eating food, you should work. Repeat the fructose part. Okay, so if you can recall your biochemistry in which we were having a lot of sugar types, sucrose, galactose, fructose, maltose, and all those things. So among the all the sugars, fructose can easily cross the portal circulation, right? So once fructose is coming to your portal circulation in unchanged form, it is going to activate two different pathways. First is what? Your carbohydrate response element binding protein. Second is what? Your sterol regulatory element binding protein. These two pathways are well known to establish to start the lipogenesis in your hepatic system. So once these two pathways are activated by fructose, you are going to have a lot of lipogenesis, right? So once you are having a lipogenesis, automatically it's going to promote the formation of NAFLD, progression of NAFLD to grade 2, grade 3, and progression to NASH. If not controlled yet, it will change to chronic liver disease. Fine, Ramya? Fine, Harini? Correct? Abhishek, for lipolysis, you need to be very active. You have to do some exercise, stop eating lot of sugars, stop drinking sodas and all those things. Because in our daily life, we are not avoiding a single penny of fructose. Cold drinks, what we are drinking. Honey, some people love honey. So honey is what? A fructose sugar. So honey we have fruit jam. People are buying that real juice and all those processed juice. It contain fructose sugar. So we are like nearby to the fructose. In our food, we have fructose. In our junk food, we have fructose. Even your soft drinks, your sugar drinks, your simple soda. Even people who are eating salad, that is fine to go if they are telling that I am eating salad with some dressings. It is what? A fructose sugar. So your whatever you are eating is completely useless. Avoid adding dressing to your salad. Just eat a simple salad. That's it. If you want some taste, add some black pepper. Do not add a white salt. Use black pepper. Do not add any mayonnaise or anything over it. Perfectly fine. Yes, even tomato sauce also. Yes, natural fruit also affects. No, Vrinda. No. The thing is, even diabetic people, so this is my dietitian diet to all of you. People who are having diabetic mellitus or any heart conditions or any other thing, people who are drinking fruit juice or vegetable juice thinking that this is more beneficial, so it is not. Try to eat fruits in such a way, in the way it is coming. So if you are making a juice out of it, you are destroying the most of the nutrition from the fruit. So do not drink a lot of fruit juice. Try to eat lot of fruit in the raw form. Fine. So I hope this part is clear. Rock salt is okay. Yes, perfectly fine, Krishna. It is okay to go. Rock salt. Yes. Others? Do we have any doubts? Any questions? Anyone? No? Perfectly fine. Okay. So let's have some clinical features and diagnosis. Okay. So I will try to make it very simple again for you people. Suppose in your OPD, one patient is coming. In your OPD, one patient is coming. Suppose he is having constipation and bloating. Constipation and bloating. You send this patient for LFT, RFT, or simple blood checkup. Everything might be normal. Everything will come normal. If you send for the ultrasound, he or she might be having what? A grade 1 fatty liver. Perfectly fine. Let's take one more example. Suppose in your clinic, you are getting one patient. Suppose weight is suppose 60, height suppose 167. As per weight and height, BMI is completely normal. Okay. If you perform ultrasound, he or she might be having grade 1 fatty liver. Why? Because of our lifestyle, cold drinks, lot of junk food, like lazy lifestyle and all those things. Now let's take one more example. Suppose in OPD one patient is coming. He or she might complain of fatigue or right upper quadrant pain. So in the gastroenterology, what we do, we draw a benzene structure. This represents your abdomen cavity. This is your umbilical part. Now this is what your right upper quadrant, where we have our liver. Here we have epigastric. Here we have our left upper quadrant, where we have our spleen, and there we have our lower flexure and right lower flexure. Done. Now patients, now suppose you are getting one patient that is obese. Suppose you're getting one patient that is obese. 100% he or she might be having what, a grade 1 or grade 2 fatty liver, but we cannot palpate the liver. Why? Anyone? Why? Anyone? Fat accumulation. Perfectly fine. So because obese people are having what, a fat accumulation, so we are not able to palpate the liver. So if you put your hands on the liver location, you can't even palpate the liver. Yes, correctly Ramya, correctly Aftab. Yes, high fats. Yes. Okay, perfectly fine. So I hope this part is fine. Remember, again, I'm telling you all, in this class, we're having around 190 individuals, but out of 191, 190 might be having grade 1 or grade 2 fatty liver. You might be not having any sign symptoms, but you are surely having grade 1 fatty liver. Okay. Now, next thing what we are having is the lab test. So before jumping to the biopsy part, let's discuss some lab test. And I need all of your interest in the lab test part now. So biopsy part is only for the higher class people. Now for the lab test, suppose if any individual is coming to you with some right upper quadrant pain or some fatigue, so what test you are going to perform? So what test you are going to suggest to your patient? Palpating is like you are pressing the abdomen on the liver part, so you can feel the liver is there or not, if it is inflamed. Without inflammation, you can't feel the liver part, first of all. So if any liver inflammation is there, then you can easily feel the liver inflammation is there, that part. Or what you can do, I think someone asked that question. Okay. uh, Ambika. So what you all people can do at home is like, on your bed, lie down completely straight, and from your upper rib, put your thumb, and from the other hand, try to hit that thumb. As you are coming down to the liver part, that sound will change. So you all can try at your home. This is your homework. So what you're going to do, on your bed, on the floor, lie down straight. From the upper rib part, the space what you are getting, that intercostal space, put your thumb and start to hit it with the other thumb. And you are going to notice a change in sound once you are reaching the liver part. This is your home activity now. You can all try. Okay, SGOT, SGPT, CBC, LFT, ultrasound, LFT. Okay, LFT with proteins. Proteins are part of LFT only. Okay. Okay, SGPT, SEOT, percussion. Okay, perfectly fine. So here we are dealing with the NAFLD part. CBC, RFT might be normal, LFT might be also normal, but let's discuss some abnormal LFT part as well. Now, we have two parameters, that is AST and the ALT. In our center, we use AST, ALT, but people are using SGOT and SGPT in this chat. So let me classify these two things as well. In some centers, AST is also known as what, SGOT. In some centers, ALT is used as what, SGPT. Perfectly fine. Now my second question. Out of AST and ALT, which is more prone for the liver now? Out of AST and ALT, which is more prone for the liver? AST or ALT? Anyone? ALT, ALT, SG. Okay. Okay. AST. Others? Okay. Now, if someone asks which is more prone, the answer is very simple. That is ALT, not AST. So ALT will be produced more from the liver than compared to the other organs. AST can be produced from muscles, from heart also, and from liver also. But ALT is more from the liver part. So ALT is the potential marker for liver injury, not AST. Okay, perfectly fine. Okay. Now suppose you are seeing some lab report and you found something that AST, ALT is elevated. Now suppose, and patients will of course lie to you that I'm not alcoholic, I don't drink alcohol, but you should be able to distinguish between alcoholic and non-alcoholic patient. How? Let's discuss. Now patients with NAFLD or non-alcoholic liver injury, they will be having high amount of ALT compared to AST. Simple thing. Yes or no? Because ALT is more for the liver part, correctly, right? So in NAFLD, you might be seeing, or in NASH or any other non-alcoholic injury, you might be seeing high amount of ALT compared to AST, right? What about alcoholic conditions now? What about alcoholic conditions now? You're going to see a inversion pattern. AST will be more elevated than ALT. Why? Now I need the answer why. Alkaline phosphate, Malika Arjun, is specifically for the obstruction. So if any patient is having gallstone or obstruction in the biliary tract, is going to have high amount of ALP. So as such of now, we are dealing with AST ALT because we are dealing with what? A liver injury. Correct? So my answer me. So why in the alcoholic patients we are having high amount of AST compared to ALT, but in other part we are having more amount of ALT compared to AST? Tell me. See, my question is very simple. Question is, in the case of NAFLD, in the case of NASH or any non-alcoholic injury, your ALT will be pretty much more than compared to your AST. But in the case of alcoholic injury, in the case of alcoholic injury, your AST will be too much compared to your ALT. Answer me why. Yes, here we are discussing alcohol only. Alcohol affect heart, lung, liver. No, I'm asking very simple question. In the case of alcoholic injury, why AST is more than compared to ALT? In non-alcoholic injury, we are having more amount of ALT compared to AST. Okay, okay. So let me make it simple. Let me answer this question. Okay. If you ever get the chance, try to visit some alcoholic patients in your ward. You might be noticing that they are getting one supplement. That is what? A thiamine, 100 milligrams per day. If you ever get the chance, go to your ward, gastro ward, medicine ward, try to find some alcoholic patients. They are getting a supplement of thiamine once a day. Yes, oh yes, Juvira, yes, perfectly fine. So alcohol, what alcohol will going to do? Alcohol will reduce the production and the absorption of thiamine. And thiamine is responsible for the formation of AST and the ALT. But if we are comparing AST versus ALT, ALT need much higher amount of thiamine for the production, right? So if any patient is alcoholic coming to you with some alcoholic liver injury, that's why among such patients we are having high amount of AST and low amount of ALT. Compared to AST, it will be increased but less than AST. Perfect. Any doubts? Simple thing, right? So my question was, among the non-alcoholic injury patients, we were having high amount of ALT compared to AST, right? Among the alcoholic injury, we are getting the complete inverse pattern. In alcoholic patients, what we are getting high amount of AST compared to ALT. So why it is? Because alcohol will reduce the absorption of thiamine. Thiamine is what? B6, vitamin B6. Perfect. And pyridine. So this thiamine is responsible for what? Production of what? ALT and AST, right? Yes, sorry, it is paradoxin. Yes, thank you, Siva. Yes, it is pyridoxine. Yes, sorry, my mistake. Yes, so we are giving what? paradoxin. So alcohol, what is going to do? It will reduce the formation of paradoxin, and paradoxin is responsible for the formation of what? AST and the ALT, right? So if we are comparing AST and ALT both together, AST need less amount of paradoxin compared to ALT. So ALT needs more amount of paradoxin. Simple. So that's why among the alcoholic patient, AST is comparatively more compared to ALT. Fine. This is your simple answer. Simple. All done. This was the answer to your question. Done. Ha, Pappu, you can drink alcohol, then you will look a report to our department. I will show you some videos. Then you will, I think, stop drinking. No issue. Okay. Daisy, the thing is very simple. It is like if you are drinking a lot of alcohol, what is going to happen? Alcohol will reduce your absorption of thiamine and pyridoxine. Correct? Pyridoxine is responsible for the formation of AST and ALT enzymes. So if you are comparing AST and ALT, ALT needs more amount of pyridoxine for the formation compared to AST. So patients with alcoholic liver disease have more amount of AST and less amount of ALT. I'm not telling that AST, ALT will not be in in the higher range or maybe normal. It might be increased, but not much than AST. Ah, yes, that's what Gotham. Alcohol will decrease the amount of thiamine and pyridoxine, but pyridoxine is responsible for the formation of AST and ALT. So we need to give thiamine deficiency will result in the formation of edema also among liver patients. So what will happen among the liver patient? They will have alter uh, ascitic, sorry, not ascitic. They will have alter osmotic pressure in the case of deficiencies. So it is going to form a lot of water in their abdomen and more infection and more mortality. Right? Simple. Done. Yes, perfectly fine. Now let's discuss the first image. So let me change my color. This is your first image. I hope it is visible to everyone. Clearly visible. Bala, I think you're getting confused. With the decreased amount of thiamine and pyridoxine, specifically pyridoxine, it is going to decrease the amount of ALT. ALT need more amount of pyridoxine for the formation, not AST. So for the alcoholic patient, AST will be more compared to the ALT. Done, Bala? Okay. Now, this is your first image. This is the completely fine liver biopsy. This is what a completely fine liver biopsy. No issue with this liver biopsy. Fine. So I want all your attention for this class because in the end we have two quizzes and I want answers from you. You should be able to diagnose NASH and NAFLD. Okay. So have this reference as the completely fine liver biopsy. Okay. Now we have next image. So for the reference, try to compare these two images for now. This is completely normal. This is not normal. Okay. So what is not normal? Okay. So in this part, try to notice the small circles. Can you all appreciate this all circles? Yes or no? Can you all appreciate the small white circles? Yes or no? Everyone, can you all appreciate? Perfectly fine. This, all white circles. Yes or no? Okay. Now, hepatocytes and the fat cells finish should be able to differentiate. If someone asks how much it should be more than hepatocytes, answer is very simple. More than 2 to 3 times of normal hepatocytes. Perfect. If it is just more than 2 to 3 times of hepatocyte, this is what a microvascular. This is what a microvascular. If it is more than it, then what? A macrovascular. Perfect. Now, let me show you some microvascular cells first. Can you all see this part? Small white circles. Can you all appreciate? Small white circles. This is what your microvascular fat composition, right? Now let me show you some big cells. See, this is big, this is big. One more big cell, one more big cells. Can you all appreciate this all big cells? This is what your macrovascular. No, PD, no. This is your normal liver. So this is your normal liver cells. If you are taking the liver biopsy, this is your normal liver. Perfect. Fine. Unnati. Yes. The next image, what I'm going to show you, what I'm actually showing you is the fat. Then what we can take? Here we are having what? A small cells, right? Difference between two is like their size. Juveria, it's a simple size differentiation. That's it. If it is small, then what? Microvascular. If it is large, then what? A macrovascular. So, okay, you only can witness the difference in size. This is pretty much big, this is pretty much slow, right? So this is what? A macrovascular. This is what? A microvascular. Perfectly fine, right? Now, this is the fat. This is the fat accumulation in the liver. Now, let me zoom in this image only for you all people. Now, here we are having more clear image, right? This is what? Anyone? This is what? Micro or macro? Anyone? Micro or macro? Macro, perfectly fine. This is what? Perfect, micro. Now, one more question. This is what? Micro or macro? Perfectly fine. Now, one last question. Okay. This is what? Micro or macro? Macro. Perfectly fine. Now, if you can remember the two characteristic features of NASH, one is what? Ballooning. One is what? Ballooning of hepatocytes. Second is what? Lobular inflammation or lobular degeneration. Right? These are the two features of NASH. So if you are getting this biopsy, you can tell my patient is having what? A NAFLD. Right? If you are witnessing the hepatocyte ballooning and how it appears like, I have some images for you all here. Now just try to follow my marker. This is your hepatocyte, correct? This is your cell. Fine. Yes or no? Can you all appreciate? Yes or no? Can you all appreciate this big cell? Yes or no? Perfect. Now in cell we have cytoplasma and cytoplasmic condensation. This is what? Your cytoplasmic condensation. This is what? Your cytoplasmic condensation. This is the one of the feature of what? Ballooning of hepatocyte. Correct? If you can compare both, look at this cells, complete white cells, right? And here we are having what? White cells with the condensation of cytoplasma, right? This is what? Your ballooning. So I have one more image for the ballooning part, this part. Now, if you can again follow my cursor, this is what? A ballooning hepatocyte. This is what? Cytoplasmic condensation. Yes or no? Yes or no? Yes. Can you all appreciate? Yes. We have one more feature along with the cytoplasmic condensation. That is what? A spider-like appearance. Can you all appreciate this spider-like appearance? This parts? Yes or no? So two things we are having, cytoplasmic condensation and what? A spider-like appearance. Correct? This is the classical feature of what? A hepatocyte ballooning. What about inflammation now? Can you all appreciate again? Now I need again some answers from you. This is what? Micro or macro? This is what? Micro or macro? Micro or macro? Then this is what? Micro or macro? Macro? Perfectly fine. Okay. Now in this image, we are having one more feature, that is what? A lot of blue dots are coming up. Lot of blue dots are coming up. This is what? Your inflammatory cells. This is what? Your inflammatory cells. Correct? Can you all appreciate this inflammatory cells? This blue dots? Others? Yes, perfectly fine. So this is how you have to differentiate between NASH, NAFLD, lobular degeneration, inflammation, and the hepatocyte ballooning. I hope this part is clear now. So if you want, you can take the image screenshot as well. This is what afterwards, once inflammation is going to happen, more inflammation is going to happen. So it will damage your liver cells. Okay. This is what, no? Uh, Ramya, this is what I'm doing, no? Yes. Okay. Wait, let me do it. Yes, we are removing Jadu. Yes, done. Okay. Now, please explain the blue dots on last image. This is nothing, just the inflammatory cells. This is what we are having, inflammatory cells in the pathological image. Yes, perfectly fine. So do we have any doubts now? Simple, right? Simple, right? Okay. The next thing what we are starting is with the ultrasound. Okay, so I need your complete attention now because pathological part is not going to be done by you people, but by the pathologist. And even though if we are giving the reports, they are not giving you the slide images as well. But in your home, you might be seeing these images. So please try to pay a proper attention with the details what we are discussing now. Okay, so let me zoom in. So what we are doing here, we are doing the ultrasound. So let me change color to yellow if you can see clearly. This is what we are doing. We are doing the ultrasound and this is what the ultrasound probe here. Perfectly fine. And this is the ultrasonic waves, what we are getting on our abdomen. Now, if you can all appreciate the presence of liver. Can you all appreciate the presence of liver? Yes or no? Yes or no? Can you all appreciate the presence of liver? Yes? Done? Perfectly fine. So, next step. Can you all appreciate the presence of kidney or renal system? Yes or no? Two things we are dealing here in the ultrasound. We are getting very clear image, that is one is renal, one is liver. Okay. So how to find whether my patient is having fatty liver or not? So what we can do? So let me zoom in. So this is your renal part. This is what your sinus, because sinus contain fat. So remember, sinus contain fat. Anything that is fat will going to shine in the ultrasound image. So sinus contain fat. That's why it is shining. This dark structure is what? A cortex. So how to find? Compare the cortex darkness with the liver darkness. This is your liver parenchyma, right? So what we are doing? We are comparing the liver parenchyma with the cortex of the renal system. So can you all appreciate the darkness? Okay, let me remove it. So can you all appreciate this is complete like lightly dark and this is light in color? Yes or no? Yes or no? Yes. See, rule is very simple. In ultrasound, fat will shine. Fat will shine. Water will not shine. Water will be black. Fat will going to shine. Rule is very simple. So here we are having what? A cortex of the renal system. Compare this cortex with the renal part, with the liver part. So liver is comparatively more hyperechoic compared to the cortex. Cortex is what? A hypoechoic, darker in color. Liver is what? A more light in color. It is shining. Yes or no? Yes or no? Yes. So this is what a fatty liver. This is what a fatty liver. So here you can make the diagnosis that your patient is having what a fatty liver. Perfectly fine. Done. Okay. The next thing what we are having here is CT or MRI. Can someone answer me whether this is CT or MRI? Let me show you two images. That is A and that is B. So A is what? CT or MRI? Which part? Winzak? Anyone? Like B is what? A or B? A is what? CT or MRI? A is what? B is MRI. So why A is like CT scan? Anyone? So why A is CT? Yes, perfectly fine. So I think you all are from the CCBGH category people. Okay. So if bones are shining, this is what a CT scan. If bones are not shining, this is what a MRI. Yes, perfect. Perfect answer by everyone. Perfect. Now, how to find whether my patient is having fatty liver in the CT image? It is again very simple. Look at the outer image. This is what your fat. This is what your fat. In CT, fat will be more black. If CT, this is your abdomen fat. Fine. Fat is like in dark in color. So what we can do? Compare your spleen with the liver. So this is your spleen. This is your liver part. Correct? So spleen is like more light in color. Liver is more darker in color. Can you all appreciate? Yes or no? Liver is more darker in color compared to spleen. Yes or no? So in CT, what we can tell that fat will appear black. Correct? Because there, see, fat is black. See, all fat black in color. What about the MRI now? Again, see, now here we are having your fat, but in MRI, fat is shining. This is what? Your back fat. This is your side fat. This is your abdomen fat. All are shining. So again, look for the liver and the spleen. This is your spleen. This is what? Your spleen. This is your liver. So liver is shining. Fine. Yes or no? Yes or no? Can you all appreciate that liver is shining now as compared to spleen? So this is how you're going to find out whether my patient is having fatty liver or not in the MRI. Now the most important thing is grading of fatty liver. You might be seeing grade 1, grade 2, grade 3 in your reports. So how we find whether my patient is having grade 1 or grade 2 fatty liver? So what to do now? Again, try to focus on the screen now. I will use different color. Now this is your renal system. Can you all appreciate? This is your sinus, correct? Can you all appreciate? Done or not? Yes, yes, yes or no? Correct. So the next thing what we are having is the renal liver part. So just try to follow my cursor. So once you are practicing all these things, then you are easily going to identify all these things, whether liver is there or kidney is there, right? Now, comparatively, if we are comparing renal cortex with the liver parenchymal, it is comparatively matching, right? It is comparatively matching. Check with the unable to differentiate liver, sir. Okay, wait, let me rough it. See, Shirin, just try to follow my cursor. This is your liver, right? This is your liver, correct? This is your renal system, right? Here we have the cortex. Here we have your sinus because fat always shines in liver in ultrasound. That's why sinus is shining. Okay. Here we are having liver. Here we are having your renal system. Now compare the cortex with the liver part. Both appear little bit more same together. Done. So if you cannot able to differentiate properly between renal cortex and liver, this is normal study. There is no fatty liver. Fine. Anyone? Any doubts till now? Done everyone? Any doubts till now? No? Clear? Understood everyone? Simple? Okay. Now, second image. This part we all have done, right? Now, this part. Just try to focus on this part only. Again, this is your renal system. Can you all appreciate? This darker color is what? Your cortex. This is what? Your cortex. Yes or no? So cortex is more darker than liver. Can you all appreciate? Liver is shining. Yes or no? Yes or no? Everyone? Any doubts? Any confusion? It's not the whole the liver. I'm going to tell you everything. Don't worry. Yes, hyperechoic. Perfect, Aftab. Yes. So this is what? So we can confirm that patient is having what? Grade 1 fatty liver. Now, how to check for grade 2 fatty liver now? For that, we have to check the hepatic vein, hepatic artery, portal circulation. So one question comes in actually Viva, we always ask this question. In the ultrasound, how you will able to differentiate between portal vein and the hepatic vein or hepatic artery? So remember, hepatic artery or hepatic vein do not have the shining layer. Remember this simple thing. Okay, hepatic artery, hepatic vein do not shine on the liver, on the ultrasound. My voice is breaking. Is it fine now? Is it fine? Is it fine now? Clear? Audible now? Loud, clear? Done. Okay. So this is the grade 1 fatty liver we all can appreciate now. Okay. Now how to find whether my patient is having grade 2 or not? Correct? Now one simple rule is like what? Hepatic artery, hepatic vein do not shine. They do not shine. But portal vein shine. Right? Portal vein shine. So if your portal vein is not shining, that means what? That is you are having grade 2 fatty liver. Now see, our fat composition decreased in the portal vein, right? You all can appreciate? Yes or no? This will you will learn afterwards in your practice. So no need to worry for this grading part. I'm just giving the touch of advanced ultrasound, nothing much to take tension. Okay. So if portal vein appearance is like a little bit more darker in color, that means you are having grade 2 fatty liver. Simple. Correct? If your portal veins are shining, if your portal veins are shining, that means you are having grade 1 fatty liver. Now suppose if your grade, this portal vein is like black like this. It's like black, it's not shining. Then it means what? You are having grade 2 fatty liver. Perfectly fine. If you are putting the probe, if you are putting the probe, portal veins are not shining. That means it is what? Grade 2 fatty liver. Is it fine now? Audible? Is it fine? Audible? Am I audible? It's better now, right? Remember one thing, if your portal vein is shining, that means you are perfectly fine. If it is not, then you are having grade 2 fatty liver. Ah, yes. If portal vein not shining, then grade 2 fatty liver. Uh, Here is the portal vein. Wait, let me draw for you. So this is the portal vein. This part. And here we have what? Your right hepatic artery, your left hepatic artery, main hepatic artery will come in all those things, right? So this is what your portal vein, this part. Now, if you can focus more on the portal part, like this part, can you appreciate this shining structure here? Can you appreciate this shining structure? Anyone? Can
Siddheesh,
you?
your voice is very, very low. No one is able to hear properly.
Okay, let me try one more thing then. Okay.
I think you should use the earphones for iPad.
No, it's not my iPad. iPad mic is mute. It's my laptop. Just give me 2 minutes.
Of course, I'll do paper. Don't worry. Simple things. Okay. So just focus on the cortex part. It is darker in color compared to the liver. So we can tell that patient is having what? A grade 1 fatty liver. The next thing you have to check for the portal veins. So here is the portal vein, right? So let me remove this color. So can you all appreciate the shining near the portal vein in white color? This part, this part, this part. Yes or no? Can you all appreciate this thing? Shining part. So if it is gone, then this is what? A grade 2 fatty liver. Now suppose, let me remove this white part. If it is gone, then this is what? A grade 2 fatty liver. If it is gone, then this is what? A grade 2 fatty liver. Simple things, right? Okay, here we have the image of grade 2 fatty liver for you, completely fine. Okay, now here is your liver. See, we have your liver here. See, now compare this portal veins. Compare this portal vein. Just look the clear image of the portal vein. It is shining now. See, it is shining. Portal's veins are shining, right? Look at the next image. It is not shining now. It is not shining. Correct? Yes or no? Can you all appreciate that shining part is gone now? Yes or no? Yes. So this is what? A grade 2 fatty liver. Simple. Yes, hypoechoic. Perfectly fine. Done? All done? Simple? Yes. Okay. Now we have next image. So two things. First is if liver is shining, grade 1. Portal vein not shining, grade 2. If diaphragm is not shining, then grade 3. Now let me show you diaphragm also in this images. Now there is the ultrasound. Here is the ultrasound. Okay. Look at this shining structure from this part to this part. This is what? Your diaphragm. Fine. Can you all appreciate the diaphragm? Yes or no? Yes or no? Yes. In the same image, can you all see diaphragm is there? Shining? Yes or no? Yes. See this image as well. Let me remove this part. Can you all appreciate little bit hyperechoic diaphragm? Yes or no? Now look at this image. Portals not shining. Liver not shining. Then, sorry, shining. What about
Siddheesh,
diaphragm? Yes.
don't enter anyone in the class now. Okay.
Okay.
Anyone.
Okay.
No, don't allow them to class.
Okay. So this is actually your grade 3 fatty liver as fatty liver in which portals are not shining. Liver is hyperechoic. What about diaphragm? We cannot appreciate now. Can you all witness? Can you all appreciate the diaphragm is gone now? Can you all see? Yes or no? Diaphragm all gone. Yes or no? Full black. Yes. Hypoechoic. Completely hypoechoic. This is what? Your grade 3 fatty liver. Fine? Okay. So this was all about the diagnosis of fatty liver, fatty acids. Now we have one more thing, focal fatty liver. Again, I'm trying to give you some advanced touch of focal fatty acids, fatty liver disease. Now, again, here we are having the liver image. So this is your liver, right? This is your diaphragm. This is again your liver. So if you can witness, can you all appreciate the presence of this small hypoechoic patch? Can you all appreciate the presence of this hypoechoic patch? Yes or no? Yes or no? Yes. This is known as what? A focal fatty liver. Focal fatty liver. Fine. Right? And how this focal fatty liver appears in CT MRI? Let me show you. So here we are having the image. So this is what? CT or MRI? CT or MRI? Why CT? Because bones are shining. Perfectly fine. Not MRI. MRI, in MRI, bones will never shine. Remember this part. In CT, bones will shine. Right? It is shining. Bones are shining. What about the focal fatty liver? Can you all appreciate this black spot? This part? Yes or no? Can you all appreciate this black spot? This is focal fatty liver. And if we are comparing our entire liver with the spleen, so what is going to happen? Liver is more darker than spleen. So we can tell that my patient is having some fatty liver also, plus he is having focal fatty liver as well. Fine. So focal fatty liver should be diagnosed with the help of some advanced or the senior radiologist. Why? Because it will mimic the presence of what? A hypoechoic lesion. So if you are completely new in this field, you might diagnose this thing as the hypoechoic lesion, and lesions are almost 99% are hypoechoic in nature only. Lesions mean cancer or oncologist will come up. But this is not a lesion, this is not the cancer part. That's why you should call some senior radiologist to diagnose the focal fatty liver. Now, for you people, you should be able to know how to differentiate between the cancer and the non-cancerous focal fatty liver. Now, suppose if your patient is having a simple focal fatty liver, your focal fatty liver patch will be very uniform in size and shape. Very uniform in shape and size. Second, mass effect will not be there. So what is mass effect now? You might have seen any cancer patients report that this mass is compressing this vein, this artery, this neurons, this muscle, this organ. That is known as what? A mass effect. So mass effect will not be there in the case of focal fatty liver. Mass effect is what? Suppose this is the artery going, this is the vein going, and here we are having some tumor or some hypoechoic lesion, because of which we are getting the compression in the artery, in the vein. This is known as what? A mass effect. But this mass effect will be absent in the case of focal fatty liver. What about patient is having some cancer? Now, how to differentiate whether my patient is having cancer or not? So, those hypoechoic patch will be very ununiform in shape and size. They might like this. They might appear like this. They might appear like this. Uniform shape will not be there. Plus, they might be a mixture of hyper and hypoechoic. So, some of them will be like hyperechoic, hypo, and some of them will be like hyperechoic. So you're getting both together in one spot, hypo and hyperechoic. So what we can do afterwards, we have to send only such patients for the biopsy and let them decide whether it is cancer or not, right? Otherwise, in the case of focal fatty liver, there is no need for the treatment. Treatment is not required. Only lifestyle modification is enough to resolve it. Okay. Do we have any doubts now with respect to focal fatty liver? No. No, Aftab. See, in ultrasound, any water containing abscess or any cyst will appear complete black. Remember, in ultrasound, liquid components will appear black. Even your, suppose in the case of ascites, you are having some abdominal fluid, it will appear black in the ultrasound. So fluids don't shine in the ultrasound, only fat will shine. Correct? So do we have any doubts or any questions? So till now, do we have any doubts, any questions? Hyper and hypoechoic in same part. See, if you can see, this is shining. Yes or no? This is hyperechoic. This is darker in color compared to the hyperechoic. This is what? Hypoechoic. If anything is shining, that is hyperechoic. Not shining, that is what? Hypoechoic. Fine. We have one more, that is echoic. That means complete dark, complete black. This, like this, echoic, like complete dark. Not possible, Chandra. No. Portal vein is shining and diaphragm is shining. Maybe you are putting some wrong your probe. You have to correct your probe. Okay. Next thing, what we are having is the treatment part now. So treatment is very, very simple for NAFLD conditions, not for the NASH. So the main thing is lifestyle. So what you guys can do, you have to change your diet pattern. You have to change your diet. The most important thing now. You have to change what? Diet. The most important thing afterwards, weight loss. So you have to lose your weight. Second, you have to restrict your calorie intake. Suppose daily you are taking around 2,500 kilocalories. So you have to change it to 2,000 or 1,900 kilocalorie. Fine. Yes, Gautam, that is what we are discussing now. So you have to reduce your weight. Cholesterol. High amount of triglycerides will cause fatty liver. If you can just recall our class starting, what we were discussing. So cholesterol you have to decrease. Yes. This part is fine. Next thing, reduce your sugar intake. Reduce sugar intake. And to be very, very specific, fructose. You have to decrease. So decrease your cold drink, your ice creams, your fast food, junk food, pizza, cheese, and all those things. Then your what you will eat, fruit juice and all those things you have to reduce. Other thing, what we can do is like you can start drinking coffee, but again without sugar. Coffee is a potent antioxidant. It will protect your liver and it will reverse your fatty liver also, but not in one shot. You have to take for a long time period along with some exercise. The next thing what we are having is the medication part. So for the medication, nothing we are using as such of now, but two things what we have in our test books to be used among patients with NASH, but not with the NAFLD. So first thing is what? Capsule vitamin E. Capsule vitamin E. You have two options now. Okay, sir, caffeine increase inflammation, true or not? No, that's why we are giving no coffee for fatty liver. So fatty liver is not because of the fat accumulation. This is because of what? Inflammation as well. So in the fatty liver, you are having what? Fat accumulation along with these steatohepatitis. That means liver inflammation. So coffee is a very potent antioxidant. So it will decrease your inflammation. Right? Now, back to our medication part. So capsule vitamin E you can take about the dose now. 400 IU twice a day you can give, or else you can give only once a day. IU once a day. Okay. Now we should not be giving corticosteroids. No, never. It's a simple natural. So there's no need to give all this high things, drugs, and all those things. No, it's a very simple management. So back to our part. So many studies, meta-analysis, RCTs are showing that capsule vitamin E is responsible to cause prostate cancer for the prolonged use. So if you are using vitamin E for the prolonged time, it might cause prostate cancer. See, Nadia, Abhishek, and everyone, we are not dealing with the NAFLD like what we are already having, grade 1, grade 2, grade 3. It can be resolved with the use of your diet pattern only, with your daily activity only. Drugs are not required to treat NAFLD. If you are diagnosed with NASH, then only we have to start some medication part. For NAFLD, we advise a simple dietic pattern, simple exercise, lifestyle modification, that's it. So remember, if you are having grade 1 fatty liver, grade 2, grade 3 fatty liver, there is no need for the medication. If you are having fatty liver but no inflammation, no need to take any medication. Okay. The next thing what we usually use is what? Pioglitazone. Pioglitazone. What is the dose now? 30 milligrams once a day. We can use for 1 month. And again, call patient back, run ultrasound, run LFT parameter, it might be improving. Omega-3 omega-3 capsule will improve the fatty liver, Harshita, because it will decrease your triglyceride amount. So some physicians are using omega-3 fatty acids for liver NAFLD patients. Why? Because omega-3 fatty acid decrease the amount of triglycerides, improve the amount of HDL. No, Pushpendra, there is no need for direct diuretics. There is no ascites, there is no edema, so there is no need for diuretics. Never. So Harshita, it will improve. Pushpendra, no. Okay. So I hope this part is done, the treatment part. Glutathione, no need nausea. See, we are not decreasing. See, NAFLD is there, no need to worry. If your liver is having some inflammation, hepatomegaly is there, it can be resolved automatically because liver will improve itself automatically. So there is no need to take any drugs for NAFLD. If you are having NASH, then start pioglitazone once a day. Otherwise, if you are having grade 1, grade 2, grade 3 fatty liver without hepatomegaly, then there is no need for medication. Just change your lifestyle modification. That's it. Diet plan, liver. Oh shit, you all are going too far away. Lactulose for constipation. Okay. See, remember, lactulose will not work in one shot. So you have to take lactulose for 2 to 3 days to show its effect, first of all, for constipation part. Liver transplantation we prefer for chronic liver disease. Yes. Why hypoglycemic drug for liver? Okay. So let's discuss this part now. Why we are giving pioglitazone for our NAFLD patients? Okay. So remember one thing, that pioglitazone will going to increase the insulin sensitivity. Will increase the insulin sensitivity where? At two locations. The most important, adipose tissue, and second is your peripheral organs, right? So once the drug improves your sensitivity, it is going to decrease your insulin resistance, right? And it will improve the NASH pattern. Yes, Manish, this is the answer, what we just discussed now. This is the MOA, how it is working for NASH. And many studies, many articles, many RCTs have shown that pioglitazone actually improved the pathological features of NASH. So it is good drug to go for NASH patients. Done. Alisha, LIV52 is only to manage the liver enzymes, but not to improve the liver condition. So better consult some hepatologist if you are having high amount of AST ALT. Okay. So do we have any doubts now for this part? Anyone? Thanks. Okay. Now let's have a quick test for you people. I'm showing you two images, A and B. Answer me, A is what? NAFLD or NASH? Seriously? PD, we have discussed all these things already, like NASH and NAFLD already. So A is what? NAFLD or NASH? Tell me, fast. NAFLD. Perfect, everyone. What about B? B is what? B is what? NASH. Okay. So let me mark some molecules for you now. So this is what? This is what? This is what? Ballooning, not blooming. This is ballooning. Yes. This is what? Macro. Cytoplasmic condensation. Perfectly fine. I'm very happy with the answer. This is what? A cytoplasmic condensation. This is your nucleus. This is your spider-like appearance. A classical feature for what? Ballooning. Perfectly fine. This is what? A macro. Perfectly fine answers. Then this is what? Anyone? Micro, macro. Micro. Perfectly fine. So you all are good now. Good to go. Perfect. Now last image. This is what? So answer me. This is what? Grade 1, grade 2 or grade 3? Answer me. Answer me. Why grade 3? Why grade 3? Not grade 2. What if I tell that grade 2 is there, not grade 3 then? Diaphragm not visible. Perfectly fine. Yes. What about portal systems? Not shining. Portal, not shining. What about liver? Completely shining. What about diaphragm? Not visible. Right? So this is what? Grade 1, grade 2, grade 3. Grade 3. Perfect, everyone. Yes, perfect, perfect. All perfect. Yes. Done. Yes. So I think we can wind up now. So if we have any question, then we can discuss. Otherwise, we can wind up.
Yes, guys. Thank you. It was a wonderful class. Even I was in the class, entire class, guys. So this wonderful class, and I saw there were some people who were doing some nuisance also, but overall the class was really, really good. And guys, now the thing is, as you know, we have a few announcements for all of you. First thing is that the feedback form. Second thing is, you know, after looking at the enthusiasm of the people, what we came up with is you guys can still register for the pharmacotherapy module 1. Okay, you guys can still register. See, all the offers are closed now because you did not you know, register within the timeline. So no offer, but you can still register at 499 for the module 1. First of all, first form, this is the first form, like what I've shared is feedback form, and the second form, second registration link I'm sharing for the pharmacotherapy module 1. Register for it. Okay, register for it. You will get such classes only in the entire pharmacotherapy. Okay, such classes you are going to get in the pharmacotherapy. So please register for this. If you are interested in pharmacotherapy, please register. Okay, if you are interested in pharmacotherapy, please register for these classes. Okay, guys. And then along with that, as we are, as Dr. Siddheesh has taken, you know, today he has taken the entire radiology part, and you know, all the things what we should learn and what we also be taken care in the diagnosis part. He has covered almost all the diagnosis, all the, you know, CT, MRI, and you know, ultrasound. So we have one more dedicated course, that is the clinical diagnostics for Pharm D module 2. In that you will learn all the radiologies. All the radiologies you will learn in that. Okay, all the radiologies, right? All the classes, like I'll be taking the cardiology part, like ECG, echo, and treadmill test and angiograph. Okay, angiography test, CAG, and Dr. Siddhesh will be taking a lot of MRIs and all, and then cancer, you know, scans and all. I mean, that entirely that is on the histopathology. Okay, microbiology is there, and lot of things are there in that. If you want to learn such classes, kindly join the diagnostic part 2, diagnostic module 2. Okay, diagnostic module 2 will be 100% on the radiology, right, guys? And I'm sharing here the feedback link and the link for the pharmacotherapy module 1. Okay, if you want to join it, and later also we will share the things. Okay, we will share the things. Okay, I think, guys, one sec. Yes. Now the feedback form will be working. Yes. Now the feedback form will be working, guys. Yeah, you can go ahead with the feedback. Yes. Accepting. Here is the feedback form. Accepting now. Accepting. Okay. Right, guys. So you can definitely, you know, learn such classes, and that's why we have come up with the therapeutics class. Okay, that is the main motto of coming up with this therapeutics course, guys, for you. Okay, so you can register, you can fill the feedback form, and that's the end of the class, guys. Thank you very much. I have shared all the, you know, things here. And if you are coming to the class, please keep your nonsense home only. Don't come with the nonsense to the class. I'm telling everyone here. There are a few people, you know, who were creating nuisance in the class. See, we don't entertain such things, and we don't want to be harsh with you. This is a free class for all of you. We conduct a lot of free classes, so please be kind as we are being the kind. You know, don't be gunda with us. That's not a warning, but kind of thing. Okay, you should understand what we are saying. So always be a, you know, when you are coming and coming to learn this thing, so learning with the patients and little humbleness. Okay, I expect that from all of you. And see, I'm in this field for a longer time, 4 years, and so don't try to be smart with this. Okay, so guys, fill the form, and that's all. Thank you very much, Dr. Siddheesh. Thank you, everyone. You can fill the form and take care. Take care, guys. Good night. Bye bye. See you. Thank you. Feedback form is attendance form, guys. Feedback form is attendance form. Okay, this feedback form is attendance form. Okay, so please fill that form. This feedback form is attendance form. Okay, there are no slides. These are not slides. He was teaching in the notepad. There are no slides. There are the live images from the patients that cannot be shared even. Guys, so you have to learn. Recordings will be shared. We'll share the recordings. Okay.